First of all, I think Dennis and I have already decided that we will definitely include neck dissection techniques and how I do it as part of the 2016 meeting in Seattle in July of 2016. I think it's amazing the interest in this. A couple of issues, and I'd like to just talk about some of the nuances, and I'd like to congratulate all of the panel for the high quality videos and even higher quality commentary around each of the videos. Jesus, you have a large level 1B mass, either in the prevascular or retrovascular facial node distribution. It's obviously extracapsular, attached to the mandible. What kind of techniques do you employ with regards to resecting that completely? It's attached to the mandible. Preoperative CT scan imaging doesn't show any mandibular destruction. What kind of things do you think about prior to surgery? What do you tell the patient? And what do you do intraoperatively?
Well, thank you, Jonathan. That's a very good question. The problem that we encounter relatively frequently, I think in that case, one has to counsel the patient about the possibility of some deficit of the lower lip because the marginal mandibular branch oftentimes cannot be preserved. Since these nodes are, as you saw in the video, an intimate relationship to the nerve. So that's essential. And in those cases, we really don't hesitate to remove the marginal mandibular branch of the nerve because sometimes trying to preserve it, you end up getting into the tumor, and that's not good. Now, oftentimes these tumors are attached to the mandible, but once you get in the subperiosteal level, you can peel it off, and if that's possible, that's what I do. I also have to counsel the patients in those cases about the possibility of having to do a marginal resection of the mandible, an inferior resection of the mandible. So obviously, your question is very pertinent, especially with regards to the counsel of the patient preoperatively.
Perfect. Thank you. Just an incredibly important, I think, area and pearl of wisdom. Again, another one from Jesus. Mark, in the end positive neck, you mentioned outstanding technique and so on, but what kind of decisions do you make prior to surgery or intraoperatively about sacrificing the sternocleidomastoid muscle, accessory nerve, and internal jugular vein? What kind of things do you look preoperatively, and what do you use intraoperatively to make those decisions?
We use obviously a combination of clinical and a radiographic. Our tumor boards are rather different, where we have all the physicians see the patients, 10 patients will come each week to tumor board, we examine them. Oftentimes we'll be looking at whether or not those patients are going to receive post-op radiotherapy or not, or chemotherapy for ECS. Some of the things that we'll decide is, we try and save sternomastoid muscle even if we have to resect some, as you saw in this video. If we do take the spinal accessory nerve, we try and preserve the cervical plexus contributions to spinal accessory nerve, which is a lower portion, which a lot of people don't necessarily do. I haven't seen it documented that much, but I think it's quite important if you can preserve those. But I mean, for us, we're very aggressive. Particularly, we do a lot of N-positive necks for skin cancer. We see a hell of a lot of metastatic squamous cell carcinoma. We've got our 5-year survival rates up around 86%, and that's due to resecting everything. So the short answer is that we'll resect what we have to get clearance. But if we can leave that sternomastoid behind, we will, because everyone's going to get post-op radiotherapy and a lot of chemo radiotherapy, and we think it's important to prevent fistula and wound breakdown.
Great. No, thanks very much. I want to get to one other area. I want to go back to the Valley of the Lost resident, Jesus. You'll remember that was level 2B, and the concept of to do or not to do, or 2A or not to, whether to not to do 2B, and the concept of when you do a neck dissection in incorporating level 2B, I think is an important concept. When do you do it?
Well, I think we have to be a little cautious here because we do have anatomical or histopathological evidence that the incidence of metastases in level 2B is low, under 2%, 3% in most studies. And that suggests that it is possible to preserve level 2 in an N0 condition. What we don't have, and I have yet to see, is outcome studies that show that if we leave 2B alone consistently and routinely, that we are not going to affect our recurrence rates on the neck. So that is lacking, and I hope somebody here will answer that question soon. That being said, we are doing this sort of in a prospective manner as an analysis of our practice. And in a situation N0, when there is the nodes in level 2A look and feel normal, and I know we cannot detect micrometastases, but if they have a gross normal appearance, we leave 2B alone. In other circumstances, larynx cancer, the same thing. There are some times where the nerve rides so high that really, you know, in those cases, we just leave the 2B alone, because to go after, you know, a little piece of tissue, jeopardizing the nerve doesn't make any sense. So those are the two instances when we leave it alone.
Great, thanks so much. Jeff, Dr. Thompson, so you played your hand with regards to your position on the prophylactic central compartment dissection. That could be a whole panel in and of itself. Your rationale is you're a doer. Basically, you are a believer in the prophylactic central compartment neck dissection. Absolutely inherent to success of that, of your surgery, will be preservation of the parathyroid glands. So perhaps you can give us some pearls of wisdom about preservation of parathyroid function in someone who does a large volume of central compartment neck dissections. What do you do?
Well, that's an excellent question. And oftentimes we end up sacrificing the inferior parathyroid glands in the course of doing a central neck dissection. But we very often will try to identify those parathyroid glands, like I showed you in that second case, and auto-transplant those parathyroid glands. But the key, I think, to whether you do a central neck dissection or just do a total thyroidectomy is to save early on one of the superior parathyroid glands. And there's not a lot of nodal tissue up by the superior parathyroid gland. And I think that you can carefully preserve at least one of those two superior parathyroid glands. And if you end up with a situation where you have transplanted two or worse yet three parathyroid glands, but one is clearly in good shape, and it's oftentimes going to be the superior gland, then that patient will do just fine. And you know, they may be a little bit low for a few weeks until the transplants kick in, but they'll be okay. And if you get into a situation where the tumor is close to the superior parathyroid gland on the ipsilateral side, then you may have to take that parathyroid gland and transplant it. And so on the other side, I would be more conservative and do what we call a near total thyroidectomy, where we isolate a little bit of thyroid tissue by the ligament of Berry where it's attached to the superior parathyroid gland, and take my advanced energy device and cut through the thyroid tissue, leaving only behind a couple of 3 millimeters of normal thyroid tissue with that parathyroid gland.
Great, thanks. Also inherent to a high volume thyroid surgeon is strategies around preservation of the superior laryngeal nerve. And I loved your video. In fact, all 4 videos were incredibly high quality. But can you go over the detail and some of the strategies that you've employed? I noticed you mentioned nerve monitoring, but some of the operative strategies that you employ to maximally preserve the superior laryngeal nerve.
Yeah. So many times the nerve has already entered the musculature above where we're going to be working, but you always have to assume that it can be in and around the vessels. And so I always try to, I don't, when I trained, I was taught to just basically take a coker clamp across that upper pedicle. And I don't think we paid a lot of attention to the external branch of the superior laryngeal nerve, but it became apparent to me that this is important to voice function in many patients, particularly older patients. So I try to take the vessels individually on the thyroid capsule itself. I use the nerve stimulator to kind of map out where that nerve is coming into the larynx, and is it away from those vessels or not. And I dissect very carefully in that prelaryngeal space between the vessels and the larynx, trying to look for that nerve as it hooks around in that upper part of that triangle. So those are some of the things that I do to try to safely preserve that branch.
Great. Dr. Nabu, two questions for you. So your area of expertise, obviously, is the management of the lateral neck in thyroid disease. Thyroid disease, at least in North America, predominantly is a disease of young women. And incision and cosmesis, and obviously function is almost as important as the outcome of the disease. I'm probably digressing a bit, but your incision planning, what kind of incisions have you employed over the course of the years that seem to give you the best access to the disease and yet be able to get the best cosmetic result in these patients?
This patient was 63 years old.
I'm talking in general, though.
Yeah, so that's why
What are some of the tricks?
So that's why I use a combination of color incision and the vertical incision. When the patient is young, I use the color incision. So I try to keep the cosmetic issue.
In a patient with low volume anterior neck disease, let's say a single one or two nodes, let's say in the level 3 and 4 distribution, ipsilateral to the disease. Let's say a 1.5 centimeter node in level 3, a 1 centimeter node in level 4, no other obvious radiological or clinical disease. What neck dissection do you do in that situation? What levels do you dissect?
Level 2A and B and 3 and 4, and anterior part of level 5B, and central neck dissection.
Bilateral central neck.
If the primary tumor is very small, then if we decide to do the hemithyroidectomy, we just dissect the ipsilateral side. If we do the total thyroidectomy, we dissect both bilateral central component neck dissection.
Wonderful, thanks. So I want to give the audience a chance now. We have 15 minutes. I want people with questions to approach the microphone, state your name, where you're from, and we have a very talented panel ready to and eager to answer each and every one of your questions. Go ahead.
Right. Abhishek Vaidya from India. My question is to Dr. Mark and to Dr. Medina. How do you address the ventral cervical rami, especially while doing a modified radical neck dissection? Dr. Mark, specifically to you, in the video you showed, you roll the specimen beneath the sternomastoid. Do you then dissect around each ramus, ventral ramus, and then get clear the specimen of it, or you just sacrifice the ventral rami? Also holds true for the cutaneous nerves, the transverse cervical and the supraclavicular nerves.
So we tend to basically use a combination of splitting of fascia and then blunt dissection. We don't necessarily sacrifice them. We do sacrifice a couple of the cervical plexus branches, but the vast majority of the time, particularly in low level 5, you don't need to sacrifice them, and we preserve them as much as we can. I mean, again, it's all about, for us, it's an oncologic procedure, and you know, we try and clear as much high volume disease as possible. If it means sacrificing cervical plexus, we do. But if you can keep those, the problem with such an extensive accessory dissection is that you can often get weakness, even if you do preserve it, particularly by devascularizing or denervating the nerve a little bit. And the more of that cervical plexus you can preserve, then the better the shoulder outcomes are. So yeah, we tend to go from posterior to anterior and use a combination of just cut down to the nerve, and then bluntly dissect forwards with a swab. Jesus?
Yeah, I just want to emphasize this pearl. You mentioned this already. The deep cervical plexus motor roots, I think, are absolutely critical. So much so, in fact, I don't use diathermy along the posterior triangle. I actually use sharp dissection because I feel that the collateral damage of using diathermy is high. My colleague, actually, Dennis Krause, has actually done some seminal work on shoulder syndrome after neck dissection. And in fact, there's so many works, Dennis, I don't know where to start. But the concept of the preservation of those deep cervical motor roots, I think, is an absolute essential.
Yeah, I agree. You know, and again, I saw Avi Kafif sitting here, and you know, even in the patient with N3 neck disease, occasionally you find someone who's got their entire trapezius nerve comes off C3, and so every once in a while, that was described by his uncle Rene in Brooklyn. Every once in a while, you'll have someone with N3 neck disease, and you can actually preserve the entire functional spinal accessory nerve into the trapezius. The other comment that I would make is what Dr. Nabu has already commented on, which is the critical nature of physical therapy afterwards. And I send every single patient who has dissection of their spinal accessory for physical therapy. And then the one other comment I would make is that we actually had a prospective, double-blind, placebo-control study at Memorial on the impact of acupuncture. And acupuncture, in the patients who got it, they actually had improved strength and decreased pain. And there was a dummy unit that they applied acupuncture. And as part of the questionnaire we gave patients to ask them if they knew if they got the acupuncture or not, they were no better than a coin flip as to whether they were right or not about getting acupuncture. So again, it's not necessarily part of medicine here in North America, but it's something that I think we did a pretty good job of showing it worked.
Did you have another question?
Yes, yes. This for Dr.
Then
Nebu.
go to the microphone.
From some of the papers of your institution, there has been a decent rate of isolated or skip contralateral lateral neck node metastasis. Do you routinely perform bilateral neck dissections whenever one side is positive?
You mean that there is no lymph node metastasis in the ipsilateral jugular node?
Yes,
And contralateral?
that's true.
I think I will perform the contralateral neck dissection, and I do not do the ipsilateral lateral neck dissection.
Yeah, I'm Vijay Haribhakti from Mumbai, India. The first question is I think for Dr. Medina, and I think the next speaker, because we often encounter large volume disease with extracapsular spread at level 2. Now, what I want to know is, what are your criteria for sacrifice of the spinal accessory nerve? Because we often feel we're very close, but we can see a definite plane, but it doesn't feel right. So the first part of the question is, what are your criteria? What are your pearls for deciding, all right, the nerve is going? And the second part is, if you feel a segment of the nerve is gone, but there is a good segment above and below, do you immediately put a graft?
Okay, so the first question, nodal disease in level 2, when do you sacrifice the nerve? And let me make it, so that was in the preoperative setting, we have postoperative radiation treatment, but also I want part B to be the node remaining after chemo-rad in the level 2 distribution. When do you do the same? So why don't we give Mark, why don't you do the pre-op, and we'll give Jesus the post-op. Fair?
I mean, of course, it's a gut feel, isn't it? I mean, extensive dissection of the nerve, you worry about that. It comes back to that cervical plexus contribution again. So we'll remove the nerve if there's any chance of leaving macroscopic disease behind on that nerve. You know, we're pretty aggressive, I'd have to say. You know, if the nerve doesn't strip off, if there isn't a plane of fascia there, then we'll take that nerve. I mean, I don't really know how to explain it. There's no criteria, I guess. I mean, if it's clinically involved, it's gone. If we're resecting a large volume of sternocleidomastoid around it, it's gone. We just try and preserve those bottom rootlets. But it's also about access and not compromising the rest of your dissection. But I can't really give you any hard and fast rules.
So complete macroscopic disease resection with the knowledge that in extracapsular disease you have postoperative adjuvant radiation treatment. Jesus. Okay, now you're in the postoperative setting. The patient's been given chemoradiation treatment, has a residual lymph node of, let's say, 2.5 centimeters in the level 2 distribution. You're dissecting. You've got a palpable node. You don't even know if that residual mass, by the way, contains viable tumor or not. And the lymph node's sitting around the accessory nerve.
Sorry, I just wanted to qualify the question a bit, because what you said was very obvious. Clearly, you don't, nobody leaves behind gross disease, but what I'm saying is there are those situations where the nerve looks all right. You know that it's a normal nerve, it's functioning fine preoperatively, and you know you can create a plane, but it's close to the disease. So you're not leaving behind any gross disease. What I want to know is, would you go really close to the nerve, or would you just maintain that wideness and get it off always? That's because that happens especially in the second situation, in a chemoradiated neck when you're operating. So
Let's go back to Mark first, let him finish that, and then we'll go to Jesus.
The short answer is yes. I try and preserve it if I can. I mean, I won't. It's the same as the facial nerve. I mean, I treat it the same as dissecting out the facial nerve. I mean, we try and preserve the nerve and its function if possible. If I think I can get it off, and I know that, most likely the patient's going to have port or chemo and post-op rads, then I'll try and preserve it, is the answer. That's my answer.
okay.
Okay.
Well,
Jesus?
that's obviously one of the hardest areas that we face, and it's just a matter of surgical judgment.
Yeah, I think
And, I have to echo what was just said, that the spinal accessory nerve is treated in exactly the same way as we treat the facial nerve. And it means that if there is a plane and you can dissect that plane, I preserve the nerve. If I have to create a plane, which I can, then that's not a good thing to do. So there's got to be a plane between the nerve that you can dissect free, not create a plane. With regards to your question, which is obviously very pertinent, and I appreciate you making it because it allows to clarify some. We do selective and super selective neck dissections in that particular situation. However, we do them with our eyes wide open. And we're looking at the tissues. You saw what we saw in the jugular vein. We're very attuned to anything like that. And when it comes to those structures, as well as the spinal accessory nerve, if there is no plane between the two, and especially in this situation, we don't hesitate to remove the spinal accessory nerve or the internal jugular vein. In fact, when we looked at our experience with those sort of salvage neck dissections, in about 25% of the cases, we end up resecting a portion of the internal jugular vein. And in about 12% of the cases, we resected a portion of the spinal accessory nerve. And with regards to the other question, if in those cases we have enough segments of the spinal accessory nerve that we can graft, we go ahead and graft them.
Great. Good point, by the way. I was going to mention grafting. I thought Dennis might bring it up as well. Next question.
My name is Nabawi from Alexandria, Egypt, and obviously my question is for Dr. Nibou. So with this patient that we have seen saying, was that a reconstructed recurrent laryngeal nerve anastomosis with the ENSA? And if yes, how long does it take for this patient after the anastomosis to come up with such a quality of voice?
Before
Thanks.
we go on with that for a second, I want to make the question more general. You cut the nerve intraoperatively. What strategies do you employ? ANSA's one. Any other strategies that you employ acutely? I know it's never happened; it's only theoretical. But let's say you cut the nerve.
Okay.
What kind of things do you employ?
My first choice is anastomosis with under cervicalis, and it takes about 1 year to the voice improvement. Yes.
Next.
Massage require from Istanbul, Turkey. My question will be in regards to your first question, probably to Professor Medina in this case. In case you need to sacrifice the marginal nerve, would you ever attempt to reconstruct it? And I was going to ask the other nerves in the neck as well, and you, in fact, talked about the accessory nerve reconstruction, but any other nerve you'd be, or you would not be reconstructing at the neck?
So let's talk about nerve reconstruction, whether it be the marginal, accessory, or recurrent nerve. A primary neuropathy on the recurrent nerve is another option, as well as the ANSA. If you obviously have length, nerve grafting or cable grafting, of course. Dennis, do you want to make any comment about accessory nerve to the deep cervical motor plexus reconstruction and options there?
On the spinal accessory?
Yeah.
Yeah, so there was some nice work done by one of our former fellows, Joe Califano, down at Hopkins. And Joe had a series of cases where he just did sural nerve grafts on the spinal accessory when he couldn't reconstruct them. And again, went through all those paradigms we talked about, physical therapy and trying to promote, whatever they can do to promote muscular nerve action. And that he found that worked pretty well in terms of restoring function. So that would tend to be my approach in those isolated cases. I mean, again, the good news is that there's only really about 1 or 2% of cases where, I find I end up needing to take the spinal accessory nerve. And most of the time when I have to do that, that's usually in really bulky N2A neck disease. And often you're having to take things like the posterior belly, the digastric, and you're having to get all the way up to the root entry zone of the spinal accessory. So I find it's the minority of cases that you're going to have a small segmental defect in the spinal accessory that's going to be easily amenable to grafting.
Great. What about the marginal nerve? Mark, any comments about reconstruction of the marginal nerve?
Yeah, it doesn't work.
Yeah.
It's probably the worst one to try and reconstruct.
Yeah.
I mean, we do quite a bit of nerve grafting and primary neuropathy, but marginal, you just look at it and it goes to sleep and never comes back again. So I'm afraid it's a bit depressing. So the answer is if we damage the marg. One of the things about the marg is it's not just one nerve, it's a leash of nerves, and it often has 2 or 3 branches. And so you can, if you're very careful, we do a lot of retrograde dissection. We won't be finding the main trunk, but we will find either end of the nerve around some nodes, particularly if we've got large facial nodes or level 2B nodes. We'll try and find that nerve, and we'll be the same as the spinal accessory nerve. We'll be very, very careful in dissecting that out. If there is a plane, we'll preserve it, and try everything you can to keep that, because they hate it. They just hate that marginal palsy.
For the marginal, when you've got an established marginal palsy, what do you do to correct the deformity?
Okay, so you don't graft it or reconstruct it. What do you do?
There's a number of strategies. To be honest, it does vary enormously from patient to patient. Botox is fantastic. Don't let anyone tell you don't Botox the other side. A lot of people say don't touch the other side, the normal side. Well, that's not necessarily true. It depends on what you're trying to achieve. Either is it voicing that's a problem? We use a combination of Botox and filler. One of the other things that make a big difference is teeth. If the teeth have gone, you need to support the back of the lip. So we'll use a combination of structural filler into the affected side. We'll use a combination of Botox, particularly in the mentalis. It tends to pull it across, so we'll Botox contralateral mentalis, and also the platysma as well, which is all trying to pull that across to the other side. We did a whole bunch of digastric transfers. Don't do them anymore, to be honest. But we don't graft.
Great. Last question from the audience.
I'm Ashok Shinoy from Bangalore, India. It's directed to the central compartment paper. I just came in towards the end of your presentation. It was great. What I would like to learn from you is, obviously you have to have a frozen section confirmation of what is the confirmation rate of your pathology at frozen section to confirm that the tissue that you send is indeed the real parathyroid. And if you're wrong, do you have a facility to freeze that parathyroid, and if there's some doubt in the minds of the pathologist to return a clear diagnosis, do you use a biorepository or something like that to deep freeze it and then put it back at a later stage? I want your views on that.
Okay, I'm not sure I understood the entire question, but you're asking me what we do with a parathyroid gland that is removed at the time of a central
That's right.
compartment
How do you
dissection.
identify, confirm your diagnosis?
Yeah,
with-
so we do, I don't always biopsy it. If it's really apparent to me that that's what I'm dealing with, then I won't necessarily biopsy it. But if there's any question about it, I will send a little tiny piece in, and everything is frozen in our hospital. The lymph nodes, that's all done at the time of the operation, so we have all that information intraoperatively. But if they tell me that it's parathyroid tissue, then I go ahead and I transplant it into the contralateral, the non-malignant side, because you're less likely to have to go back in on that side later on if you have a recurrence. So that's basically what we do. Does that answer your question?
Yeah, and how many parathyroids do you need to transplant in a particularly very aggressive disease to get normocalcemic? I believe it takes about 4 weeks, but what is the number that you require to, I think I heard you said 1.
Well, I
Is
think
that right?
if you leave one well-vascularized, parathyroid gland that has normal color, I'll oftentimes take a little needle and stick it into the parathyroid gland to make sure that it's bleeding, because sometimes a totally devascularized gland looks very normal, as opposed to a gland that has good arterial inflow but not good venous outflow, and then you get this purplish-looking gland. So, that's basically what I do. The more parathyroid tissue you auto-transplant, I think the better the results are going to be downstream. I try to if I'm going to auto-transplant, I try to auto-transplant 1 or 2 glands and try to say, but if 3 of them don't look good, you should auto-transplant all 3 of them.
I want to thank our panelists for an outstanding panel. Thanks so much. We'll see you in July 2016 in Seattle.